All right, we'll go ahead and get set up for this next panel. I am super excited to have with me Nilsa Cruz, Lexi Ramchek, and Danielle Rome-Martin. We're going to be talking about rheumatology, gastroenterology, and neurology, essentially infusion-based products, as well as private practice. So super excited about this one.
Hey, hey.
Check, 1, 2.
Mic one, mic one.
Switched off. If you need,
Good
I
to
had
know.
to switch it off. Sorry. I didn't know if you were going to go right away.
Of course I'm going to start right away. We're having a little bit of the room changeover, so we totally understand everybody. We're just going to kind of keep it rolling. We appreciate the casual conversations that we're able to have on this last day, and we appreciate your participation and attention and willingness to hang out with us on this lovely Friday. So if each of you could quickly give a quick little background, who you are and what is it that you do. Nilsa, I'll pass to you.
You get to go first.
Hello, my name is Nilsa Cruz. I am a practice administrator at a solo rheumatology clinic in Milwaukee, Wisconsin, and also a patient advocate.
Do you want that back to you?
We'll share.
Hi there, I'm Lexi. I am a pharmacist by training, but I am one of two supervisors of the specialty pharmacy prior authorization team at Advocate Aurora Health. We're one of the top 5 health systems in the country, and so I cover all disease states and specialty, but autoimmune has a special place in my heart.
Hi, I'm Danielle Rome-Martin. I am a clinically trained occupational therapist and an adjunct professor at Columbia University. And my honor has been serving the last 11 years in the homes of families, right next to them, living their journey. So I hope to be able to bring that perspective today.
Absolutely. So the thing that I like to do with panels, especially with a group like this here, because I know you're not afraid to share your real thoughts, not just opinions, is ask the questions, and I want to provide solutions, right? Each one of these ladies has developed processes, plans, have networked with others to really truly create the environment that they work in, which is admirable, and I would love for them to share all of their tips and tricks with you. We just don't have the next 3 days to do so. So the kind of first question I really kind of want to roll into, right, and it's generic to you, is, are there any problems? I mean, that's rhetorical, don't answer it. So current challenges you're solving for in your specific entities or practice setups, right? I know I'm in the private practice world, and insurance is essentially our physician, but just to give, Danielle, go to you, just give some highlights of any current challenges you got going. This is a venting session too.
Is it? Okay, great.
Yeah.
Because I can really talk about some of the current challenges, and mine rely on patient education. My patients, which I think you all know, sometimes will get that denial or that EOB before the doctor does, before anyone else does, and they fall apart. They are highly concerned, they're scared, and they typically don't go to their doctor, they don't call their office, they come and vent to one of us that are in their home, and a lot of the times we don't have the answers, and that leaves us in a really horrible space. So I think part of it is knowing that one of the challenges that I have is that we work in silos. And that is a big challenge for me. And I don't think that unless we start branching out and really connecting to who else is with our clients and our patients day in, day out, we're not going to be able to holistically help them survive this situation.
I would say we were just talking about this out in the hallway before, but the biggest challenge is just that pharmacy coverage, especially for all walks of life. The commercial patients with the alternative funding plans, the maximizers, accumulators, and then our Medicare Part D population, helping them be able to afford their medications. And then even our Medicaid population, that we had a number of Medicaid patients that were kicked off their insurance July 1st or July 31st and didn't even realize. And so just that education and just so many areas that do need support to get their medications.
So at my clinic, we have a total of 5 people. That's a physician, myself, and then 3 supportive staff. And I do anything and everything administrative, and that includes the prior authorizations. I know that you told us before this meeting there is no way that we're going to say prior authorizations are a challenge unless we bring a solution. And definitely, I landed on that solution not too long ago, and I am just flipping those cases like you would never believe. My patients are finally getting access.
So prior auth, the big scary word in the room, but, and I'm asking a question, so manufacturers, if this is gonna hurt your heart, please plug your ears. But what about challenges with the manufacturer resources? So oftentimes I get feedback, I'm pro enrollment forms, as I hope everyone else is too, but not everybody is. So what are some challenges we're having, especially in this space, right? I feel like the infusion space, especially, neuro, gastro and all that, Rheum is, they're infusionists at heart, so I hear, specifically in this area. So if you want to kind of touch on that with the rare disease and all that. So you got a mic, go ahead.
Yep. So I will say our health system is not very start form or hub form friendly because we've had we've had some data leakages that have led to some concerns with some pharma parties. I think the most frustrating thing is that we don't know that the patient has like an accumulator or a maximizer or even alternative funding until that copay card runs out. Until that patient is calling us freaking out that they got told they have $3,000 they have to pay CVS, or Optum shipped the medication to them and now sent them this bill and they didn't agree to this, they didn't know about it. And so just the way that the copay cards work. Some companies have gotten ahead of the curve by putting kind of like stop blocks on like dollar amounts and then giving like a credit card to use instead. But I think like the most frustrating thing is that copay card situation, and just like we don't know until it's too late usually. And then manufacturer assistance is now starting to deny them because they have commercial insurance, and so ultimately we end up either changing their drug or putting them on an infusion, but there's not good answers. And kind of similar to the last panel that said, it's stupid to put someone on something else that's working for them. Like you want to keep them on the medications, and so that's where it gets really frustrating.
So in rheumatology, enrolling patients on, first of all, insurance verifications, then copay card and patient assistance. I'm going to be bluntly honest. I think pharma, and I used to be pharma for 12 years, many months ago, is doing not the greatest job lately, simply because we are playing this cat and mouse chasing game right now. Because you have these benefits spelled out in SPDs, which is what the employer's ultimate payer is, not the BUCAS, it's not Blue Cross, United, Cigna, and Humana, or the PBMs paying for these claims. It's actually the number 2 largest payer in the country, which are self-funded plans. And they're inserting these kind of languages with exclusions, accumulators, maximizers, and whatnot, pushing patients into PAP programs. Pharma is reacting to that, understandably so, right? It's their money, but self-funded are saying, no, it's really our money. It's making it really interesting because what used to be the website that I had kind of put on my favorites is no longer the website. And it looks like you have to really navigate what you think you're in the right website, then you suddenly have to go into a little something corner right over there to be able to get into the right part of what you need to do. It's complicated. The forms are changing, and they're changing at the speed of light, not necessarily with enough timely notification to the physicians and providers' offices. And somebody forgot to think about the fact that people on our end have to be retrained on how to do these things over. And all of these because of this cat and mouse game. That's very challenging.
So I'm going to chime in back for a second on the copayment cards and with a little bit more of a solution. So your example with the families getting this bill or getting the drug and then getting a bill, I just want to try to preface and have everyone here remember, and I think we all can agree that our families naturally when they're going through a medical diagnosis, they're depressed. And they may not be depressed enough to have a diagnostic criteria for depression, but they are depressed. And what we see first happens with depression is we lose our cognitive ability to take working memory and change it to long-term memory. And what happens then is the way they explained the copayment card and the way they understood it, they did not transfer that to long-term memory. They have forgotten it. So if there's a solution that we can have as visual and as low health literacy possible to make attached to that copayment card or explanation is the best way for them to be able to have a visualization to remember how that copayment card works. It would be my solution in some of the copayments that can help.
Yeah, absolutely. And I think it's a really great opportunity for us to use our voices, right? Pharma's our partner, right? We are all in it for the patient. We've said this a dozen times over the last few days. And, you know, I'm loud. My individuals that call on me know that I'm like, hey, this is a problem. This version 4 of this enrollment form, and I'm still sending version 3, and they kick it back to you. Yeah, it happens. But we're partners, right? We're all trying to work together. So, you know, yeah, absolutely you can.
The other problem that I'm seeing too is that when pharma, and look, we cannot live without pharma. They actually make drugs that are disability sparing and save lives. No one else does. So we need them. We need them at the table. But when they uncover that there is an accumulator or a maximizer, that $20,000 copay card or $25,000 copay card suddenly becomes reduced. It is literally reduced for them to try and fight what is happening at the self-funded employer level that have these two maximizers or accumulators on it. And the last ones to know are my office and my patients.
So kind of going into this, and we're talking about education that's provided, so benefits are super important, and especially in this space. One thing that we're currently facing, and Nilsa, you'll probably be able to speak to this immediately, is the downcoding on administration for IV infusion, right? There's generic codes, and then there's chemo codes. So one reimburses higher. Obviously, the chemo code reimburses higher than the generic coding. And so we're facing a lot of pressure from payers on what code we can use or can't use and what our reimbursement rates are. But those typically are not included in benefit investigations. So I know this is a really hot topic right now, and there's a lot of legislative action going around it, but anything you want to speak to on downcoding?
It's a catch-22. When benefits investigations do take place, I do like to provide the correct code. I'm a certified rheumatology healthcare coder, so I do like to provide the right code for them to be able to get information back to me. I'm also a member of the payer response team at the Coalition of State Rheumatology Organizations, along with 2024 Advocate of the Year, Julie Back. And together we fight this, right, Julie? So through the CSRO, we have been able to actually engage Dr. Maddie Feldman and her team, CMS, to be able to recognize complexity of coding for many of our infusion and injectable medications. It's interesting though, really interesting, when I am doing a prior authorization, I also submit those codes because I want to make sure that on the back end, after I submit my claim, someone like, for example, Humana Medicare Disadvantage doesn't come back and say that that code is the incorrect code. However, having said that, it's not as easy because the BUCA plan, they're not payers, they pay for nothing, right? The BUCA plan will come back and say, oh, that code doesn't need to be PA'd or pre-D'd. And that is how they get you. The comeback and solution to that is, this is a large dollar amount claim. The patient has an out-of-pocket, And now with the transparency law, where I am supposed to provide an estimate for the patient on the expenses for these treatments, the patient, remember, is demanding to know.
I've faced some of that in some of our practices as well. Anything on downcoding in your institutions or what you guys have going on? Or hear about the lovely rumor of it?
I don't really deal with infusions. I'm more on the pharmacy side, but I have been seeing a fair amount of medications being pushed to set up buy and bill, being white bagged. Also site of care restrictions. We have a lot of, especially commercial insurances that will only let the patient get maybe one infusion at our site because we're hospital outpatient departments, and then they're forced to go somewhere else. And so I've been trying to send as many as I can to NILSA actually, to keep them in a trusted infusion center versus these like I don't even want to say like these Burger King type infusion centers that are popping up left and right and that are like demanding to have my business, and I just don't trust them because they don't have a doctor on site. And I know you taught me something about the wording that like when the physician signs that order for like those outside infusion centers, if something happens to that patient, it's your physician that they're coming after. It's not them that's taking the risk, it's your physician when they sign those sites. I said that right?
Right.
Okay. And so I've been really trying to send my patients either to like our home infusion service or to NILSA, actually.
So I'll make a comment. I might be out of my scope here as an occupational therapist, but we had a great conversation this morning about downcoding, and what we're seeing is when we're trying to get any type of services or anything, even home health aid services, they're pulling every document that is involved with that patient. So the more downcoding there is, the less opportunity they have for the assistance that they need.
Correct. And so you brought up an interesting point about sending patients to a reputable center for infusion. So there are great organizations out there. There are different rules in different states. So what does that look like from your pharmacy perspective, getting those patients out and sending those? What are your relationships with the ones in your area? And, we're solution oriented here, I promise.
Yeah. So I really do try to partner with the infusion sites that, one, have a doctor on site and also aren't putting like the risk on my clinicians. I do try to talk patients, if I can, into like our home service, which they can't as Medicare. So I really try to partner with sites that I know are trustworthy and will take care of my patients. Also the ones that do help with like the financial assistance or some of those like copay support. And so it's kind of far and few between in Wisconsin. So that's why, again, I send a lot to private practices, private infusion, like private clinics, because they actually have like the appropriate staff.
I like to add to that.
So one thing that we have found, and I believe Julie Back also does this in Missouri, when you find a trustworthy partner and you're sending an outside referral to a private infusion site, it's always good for that outside referral pharmacy or hospital to know that the private, in this case, rheumatology practice, is going to be able to directly communicate with the ordering physician, because the ordering is on the outside and then the private doctor picks it up from there. So there's that second order, right? Which mimics the order from the outside. But one of the biggest complaints that we have seen, not from my office, but from other outside infusion sites where patients end up coming into my clinic now, is a lack of follow-up. So they want to know that their patient got treated at the site, right? And how many infusions or how many treatments. So there is also a nice follow-up that's been given. That is called continuation of care. That needs to happen, because some of the fear is that if you have a facility sending to an independent, well, maybe everything stays there, and it depends where you sent out, And
I think with us and the experience that we have, and Nilsa, you did a talk about social media and utilizing that, right? We're here to change the rules. and not necessarily the rules. We're here to change the game. We want patients to have access in safe, appropriate environments. And I think a lot of that starts with our providers. So I know I am huge on provider documentation and education. And I know that every one of us in this room who works with a physician or a provider, right, we're constantly given feedback. I used to call them love notes that I would send in the EMR of like, when was this patient's last ER visit? What is their lab value? Like, did you do this? Not because I'm telling them how to be a doctor, but because I need that to do my job. So I think, Danielle, going from the education side, right? Like, I think there's so much more room for provider education on access. So talk a little about your feelings on that. Again, we're trying to change the rules here.
So it's actually super funny that you bring that up, and this is my own personal experience. I was recently at a doctor's office, and they were going to prescribe me a medication. The doctor says, it's not going to get covered by insurance, it's very expensive. And I said, okay, well, what's the copayment assistance? What are the copayment cards? He says, I don't do that, the ladies in the office do that. And I said, excuse me, sir, if you're going to prescribe me a medication, you should know how I'm going to get it. And that was my own experience. And it felt uncomfortable for me as a healthcare provider. And I think about my patients and my families who are in that position, who may not have been comfortable to speak up, who may have said, okay, and we'll do it. And so I think that not only is there's provider education on the processes, but there's also, I think, a true cost of burden is what we're taking from these families. Those stressful moments when they think about that bill and how they're going to pay these entities that they have to in order to get their medication, the length of time it takes, we're taking away small moments of their life, and I see it in home care. They're disengaged. They might be cooking and not paying attention to anything. They're not regulated, and they're never going to get those moments back, even when they get the payment or the co-pay assistance. The longer we take and the choice of words we use will, I believe, we can make that change to diminish the moments that they're going to lose from their life, even if they get the payments.
Follow-up question, just going to ask you. So for a provider saying that, does he know you work in healthcare? Or was that?
No provider knows I work in healthcare, and that's how I get them later.
Yep, I'm right there with you. Yeah.
So at my clinic, my doctor the rheumatologist makes his medical decision, and next thing I know, at my office, I have a white coat standing next to me that says, I just saw so-and-so. This is the drug that we agreed on. Do you think the patient can get on therapy? And I'm looking at him and I say, you're asking me, you're the doctor. But because things have changed so much, I truly cannot expect him to know what's covered or not covered anymore, because what's covered today, in 6 months, that formula is going to change again. I mean, it changes, 3, 4, 5 times, a year, if not more. I like to read plan documents for these self-funded employers, and I can tell you guys, I have literally seen language, and I spoke recently on this on a conference in Wisconsin. It was called Don't Feed the Beast, and the beast is a set of behaviors. And literally, I have seen language in these self-funded employer plans that state, well, number one, whatever extra money we make, we don't have to give it to you or to your employees, patients, co-pays to reduce anything. But number two, formularies could change with, and I quote, no prior notification to you, and they can change as often as 6 times. Imagine you're the patient on a certain drug, established already on that medication, having to go to a pharmacy and suddenly finding out that that drug is no longer on formulary. So yeah, the white coat stands and says, and then the other thing that we have to look at is insurance. Isn't that terrible? That we have to look at insurance coverage to be able to determine which medication the patients can get?
I'm going to propose a solution that we did. So our pharmacy tech team that does our prior authorizations, they are not clinical. And if it is not in the chart note or documented somewhere, we can't make it up. And so we were finding that we were having a number of denials because the doctor, our PA, the clinician did not indicate, patient can't take methotrexate because they're trying to have a baby, or patient is an alcoholic, so again, they can't take like if you don't put that in the chart note, we can't make it up. We can't guess, we can't read your mind. And so I actually worked with our clinical informatics team to make a smart phrase that kind of answers those questions with, so it's like, I'm prescribing X drug because of this. The patient has tried and failed this. The patient has contraindications to X because of X, Y, whatever you want to call it. And so it's actually been pretty successful and really helpful for our team to have it in the documentation so that they don't have to kind of go back to the doctor, or they don't have to guess, or they don't have to get it denied because it wasn't there for them to know. And so that's something we've worked on.
So my mind's blown here, and this is now my turn to ask questions, so I'm just going to focus in. So one of the things that I find that we do is we talk about when we want to hire someone in prior auth, right? We want somebody with years and years and years of experience. We love it when they're clinical, right? Because it's faster that way.
Yes.
But you just proposed a whole different idea of taking someone who is not super familiar with that, and you're asking them to read, because it's whatever the policy says has to be in the note.
Yep.
Is it a learning curve for them? Like, how do you find just the process in general? I'm so intrigued.
Yeah, so I would say definitely, oh, sorry, I'll bring it up. One of the big things that we did as well is when we have our teammates, we kind of put them into a specialty area, so GI, derm, rheum, neuro, oncology, etc. And my counterpart Pam in the back and I cover Wisconsin, she covers Illinois, but we've really teamed up with like the medical science liaisons to get the employees, our teammates, the disease state education to understand like why rheumatoid arthritis is important. You know, I'm not trying to downplay oncology at all. We all understand oncology is important, but they never learned about like maybe uveitis or Crohn's disease, or the fact that like if you don't get this patient under control with their flare, that they could be going into surgery and having part of their intestinal tract removed. And so number one is disease state education. And then kind of trying to call out what some of these terms mean, like corticosteroid, like what does that mean? What is that drug name? What is that like? What are you looking for in the chart? So we really try to like kind of hold their hand and help them through it in the beginning and kind of give them more autonomy and more independence and kind of move it forward. But the smart phrases have really, really helped.
And do you have to almost beg to see an MSL or medical science liaison? Because they'll call in the physicians all day long.
No, I feel like I have a really good relationship with our MSLs once they kind of learn what I do, and usually it's me or Pam that's reaching out to them and finding them because we need data. And then once they kind of realize like we're the team that's getting these medications approved, they won't leave us alone usually, which is a good thing.
That's fantastic.
I just want to say I'm kind of blown away. So the EMR systems, when they came through as a provider, especially Epic, that was supposed to be like the nectar from the gods. That did not happen for all of us.
It's not? I thought everyone loved Epic.
Oh, Lord. But so, we were all, the idea that you took an informatics team, an informatics nurse maybe, and used the system to create a better system, I just applaud you. That's phenomenal.
Yeah, absolutely.
I have more to make, but
I love that.
I'm just sitting here thinking, I am a third-party solution for physician practices, and I've spent most of my career making people more efficient at prior auth, and it's been great. And it's always been like, give me this background, give me this, and what a great idea. Like, sorry that I'm in real-time processing up here, putting this into place, but I think that's fantastic. Nilsa, you want to talk about? I know, so you do most of the prior auths in your office and all of that.
How about
Who,
100% of them?
who's your backup when you take vacation?
I don't take a vacation. I do work remote, 100%, 100%. So my billing, my EHR, everything, it's on the cloud. So it allows me to do that. I never believe on hiring someone to help me with prior authorization. Prior authorization is such a BS issue that only delays and denies treatment for my patients. I know that I have to deal with these, and when I go into it, I always think I have one shot at getting this right? And that's my mentality. Same thing when I submit a claim for billing. I have one shot. I better don't forget a modifier. I better don't mess up with the number of units, because it's going to be hell having to, resubmit the claim and whatnot. But I will say this much. When it comes to prior authorizations and your system is fantastic. What I have seen lately is that even though you have everything documented to the T, all of the reasons in there, you have some stupid AI something at the BOCA end that missed keywords. And I'll give you an example. Lexi, a while back, sent me a patient that was stable on Remicade. I think I presented that case when Julie and I were talking about social media is the new prior authorization. What was not said on that slide is that the reason why the prior auth was initially denied was because Blue Cross Blue Shield Illinois indicated that for Remicade, which as all we know here is a weight-based medication, the patient weight was not included. You remember that one? What a fiasco. The patient weight was on the first line of page 1 out of a total of page 1 on that PA request. And it was denied because the weight was not included. So I resubmitted, and I said to Lexi, look, I need a letter from your GI doctor, because it was a GI patient we were treating, and I'm going to have Dr. Rosler also write a letter, and we're going to go with the weight in tandem on the first page, line 1, and let's see what happens. And we did. And guess what happened? It was denied because the weight was missing. I knew immediately I was dealing with some really bad algo on that end, you know, and then something else ensued. That was social media. So you can have all of the documentation that you think should be there and all of the justification, and in the end, if you get a bad algo on that other end, and trust me, they're there, waiting for you to just delay and deny, you're going to have to go through that process of appealing a claim.
I'd at that point write on my cover sheet going back, stop asking me about my weight, that's rude. But that's the kind of petty things that I would do. And it's great that you guys have this relationship where you can work together and talk together. And I'm going to selfishly plug that you have a great community here within Healthcare Advocate Summit and all of us. I mean, we're all friends and cohorts on the back end as well, but I'll toss it to you down there, Danielle. What communities are you a part of? Where do you find resources? Who all do you talk to? I know there's ones like NHIA, National Home Infusion Association. I know I'm active with NICA, the National Infusion Center Association, and NORM, National Organization of Rheumatology Managers. Just trying to spell out these acronyms for you. But where are you kind of going? What communities are you leaning into?
So let me start with my governing body community is AOTA. And after last year's conference and I went back to my professor, I said, anyone ever hear about all of this? After I cried in my hotel room knowing I didn't help any of my patients. Nobody did. And so that's a thing for me because I don't think as home care therapists, we're in the beast of it all and we're just out there and we're trying to make smaller communities to help each other. But I will tell you that the problem I have is I know my governing body is not, they don't know patient advocacy. They don't know that you exist. And on top of that, some of our clinics, multidisciplinary clinics, and I can name some big ones, also are not connecting with the right communities. So I don't want to say that I have the communities. I think that on my end as a rehab therapist and as someone who's in the homes is we need to start building the communities. We have to, back to silos, we have to stop working in a silo because we don't live, we're not humans in a silo. However, I think that there is a huge amount that we can do in the student community right now and connecting with the students before they become healthcare providers, before they lose touch with everything. And I wish I could go back to learn more of what I did from 11 years, but I will keep doing it now.
So I'm a coalition gal. I do believe in coalitions, and I do believe in the power of one big, loud voice. I also love to collaborate and find those with a voice that oftentimes could potentially be louder than even mine, such as Julie back in Missouri. So we learn from each other, right, Julie? She's balls against the wall and I'm more politically correct, but we get the job done for our patients. I love working with the Coalition of State Rheumatology Organization because their advocacy letters are very straightforward. I wouldn't call them aggressive, but they're right to point, and there's just no going around and beating around the bushes. Other organizations are great as well, but CSRO's advocacy letters are fantastic. And lately, I joined another really big organization, which I think should be part of the summit next year. It's called AIA, Autoinflammatory Arthritis. And from the board to the CEO to the CFO to the people at the camera to the ones calling on the senators and the legislators, all of them happen to be autoimmune patients, very, very savvy patients. That's a great organization. Julie just got invited to be a board member in that, and I strongly urge the summit to take a look at it for next year.
Lexi? Where are you going for community and knowledge, besides obviously here?
I definitely would say here, or Nilsa too, when I have some tough cases, usually Melissa is one of the first people that I text. Melissa has really helped me get some connections that I've needed, Nilsa as well. I'm going to my FRMs, I'm going to my key account managers for like the different medications. I'm trying to get to like the policy experts at the pharmaceutical companies. Trying it all. I have a really, really difficult oncology patient that I've been dealing with since like June, and it's just been so frustrating. And like Nilsa and Melissa and Anne, I don't think she's in the room anymore, have all been really, really great support. And ultimately this is turning into a huge lawsuit for this patient, and it's just like become such a mess. But just having like Pam, definitely, but yeah, like the policy people as well.
And we talked oncology earlier, and I'm going to talk allergy after lunch. And it's so interesting because we're all doing and facing the exact same things. And one thing that I find, I think oncology has, just coming from the outside perspective, they have so many communities that's like you're in one of the clubs, I try to be in all of them. But it's, in some of these other smaller specialties, like I know in allergy, we don't have this kind of community level. I mean, I've got some of my allergy people in here, we're actively working on that. But yeah, I'm with you.
I want to add one more
please.
thought on that, on the communities, because you reminded me of it. And I think, Nisa, you spoke about this on social media. When we're working as a rehab therapist, if someone in a rare disease would get a new wheelchair, we all wanted that wheelchair. Who went out on social media, it was the thing, we all had to get it regardless of if they needed it or if it was the best fit. But I think that patients are actually the community. I messaged Melissa, and in a heartbeat, she returned my message with about 5 resources for this one family that was told by an MDA clinic there was nothing they could do by email. And I know that they have spread those 5 resources to a massive amount of other MDA patients, neuromuscular patients, to be able to do it. So I think it's also engaging the patients who are ready and willing to advocate for their community and allowing them the opportunity and the resources to do so.
I sit in a lot of patient groups on Facebook, especially for asthma and food allergy. While I'm not a patient of either one of those, I really do it for the education because you're right, patients are the loudest. At the last meeting I went to, I think one of the best posters I saw had to do with social media and like asthma, right? What is trending? How many hits were there? How many, likes were there on posts over the course of like a month? And it was astonishing to me that so many patients were looking to other patients through that route. So, yeah, of course.
So speaking of patients, right, because they are the drivers of everything that we do here, I recently learned that physicians and advocates, when it comes to getting patients the treatment that they have been prescribed and or they need, are not as important to the BUCAs and or the PBMs. In fact, physician and providers are considered, get these guys, big news, independent contractors for the Blue Cross, United, Cigna, Aetna, Humana plans of the world. We are all independent contractors, which means that when I write an appeal letter, I'm not as important or significant than as of when the patient is driving these. I always say, hug your patients, at the clinic, bring them shoulder to shoulder with you, because you really need them as much as they need you. They need you for the guidance on how to do this, but in the end, it's them who really have to push this through with you right behind them to catch them if they were to ever fall. So the patients have to drive everything that we do as advocates. We're simply there to support them. And that was a hard lesson for me to learn, because I have been doing this for over 25 years. And I thought I would be the one signing the letters, or my physician would be signing the letters. And I learned that that's not how it's done. If you want to flip this quickly, it has to be patient-driven.
Absolutely. So I kind of wrap this up. I want to leave a little time for some questions. Danielle, I'll start with you. Can you just give me some last thoughts and kind of, I don't know if necessarily a call to action, but in this space, right, and in your experience, is there something worthy of note, something we should look at? I mean, say whatever you'd like.
Anything?
There's no rules, remember?
No, I love that. I think my biggest call to action is to truly, and Nisla, you said it earlier, it's patient-driven, but to remember what they're imparting onto you, what's going on in their life, is maybe this much, because they're trying to stay pulled together, because most patients still believe if they are not pulled together in the healthcare system, they will not be provided anything in the healthcare system. So they're not going to tell you about the other mounds of bills that they're going to have, the other situations that are going through, the other stress levels. So if we can just remember that your experience with them is just this much along this line, and take that into account of how we can accommodate and educate, knowing that they're only retaining maybe 10% of what's happening around them at that moment. And that's okay, because they're in survivor mode. So I think if we could just remember that, how can we lessen the burden of survivor mode?
I would say definitely utilize your resources. Again, there's probably some people that aren't familiar with using like the field reimbursement managers or the MSLs or the different terms that I'm throwing out here. But a lot of times that FRM is your best friend. I can think of 3 different patient situations in the past month where I've had patients like crying and screaming at me on the phone because they're just so frustrated and upset. And one of those patients said, "You don't effing care." And I'm like, that is not true. I do care. And it escalated. It was actually an infusion issue. And I deal more with specialties, so like the oral and the sub-Q, and it was a AbbVie drug, Skyrizi. And this patient had been waiting since April to start her Skyrizi, and it kept getting denied because it was a new indication for UC that just got recently approved. And so it wasn't recognized by her insurance. And so I actually went over the head of the infusion team, and I got this patient the bridge doses with the FRM so that the patient could start the medication. She just got her second dose yesterday, so she's been on it. And sometimes you have to kind of piss other teams off and just take the bull by the horns. And when Pam and I first started our role, we pissed a lot of people off. I didn't know that there were certain teams. I didn't know that there were certain people in these roles. And yeah, I made a lot of people mad because I just wanted to jump in and fix the problems. And so we've definitely made a lot of headway, but there's still a lot of way to go. And so I would definitely encourage you to utilize your field reimbursement managers, to utilize the bridge programs, to learn about the alternative ways that you can get patients on medications.
And Lexi, what you do not know can't hurt you. Actually, because if you don't know it, there's absolutely no fear. No fear. You stay focused and also very open-minded as to what other resources, that's such a big word, you know, and we're so used to I'm so used, not anymore, to the same old, same old, same old. Use the resources, use the resources. I'm so fed up that I say I needed different resources. I don't know exactly what I'm looking for, but it has to be different and spicy and something that will actually get my patient going. So resources. I started reading plan documents. I like to know how those who are paying for my patients' medications think. That plan document governs all the benefits. We are not used to looking at plan documents here for these self-funded plans. Number 2 largest payer, guys. I'm telling you, this is a huge thing. Everything is spelled out in there. I cannot begin to tell you, Elizabeth, how many times have I received a potential denial based on from a BUCA based on a national published BUCA policy, because that is what they use. And they're acting as third-party administrators of that given self-funded plan, meaning they're not the ones paying, the employer is. And when I get a hold of that self-fund document, literally it's either given to me by the patient or I obtain it through the insurance portal, most of them, most often than not. Language is different. Sometimes there is nothing in there that says that that treatment is not covered, right? So it allows me for me to be able to challenge that. So that's one great resource. And then of course the other resource is, actually it's not a resource, but it is a big resource, is this job right here. I didn't ask, I didn't sign up for it, I just kind of was baptism by fire. Keep in mind that it is very hard to do, and there are days when you literally are so freaking exhausted. So this is when you reach out to each other, which is why I love coming to this summit, because I get to meet so many people from so many different backgrounds, going through the same thing that I'm going through. And if you have those contacts on one of your, downtimes, take a little break, reach out to them, excellent resources. Little would you know that they're going through the same thing that you are, and it's like a great supportive advocacy group. It may sound corny, but it really works.
I mean, that's how I met Melissa and how, we've kind of gotten to where we are here. So I'm going to turn it over to some questions before I stand between you and lunch. Does anybody have any questions for this awesome panel that we have? Or are you guys all still tired from the pool party? Because I am too. All right, I will end this with just a quick note that our next panel will kick off at, and let me check the time real quick here. We will kick off at 1:15. We're going to be talking about allergy, immunology, a little bit of derm in there as well, and some immunology, just kind of talk about some challenges that we were facing there, including some really big issues with a national payer that we're having in the Blue Cross space. So, all right, we'll see you guys after lunch.